In this section now we will discuss the prognosis and mutations of gastrointestinal neuroendocrine tumors. And the topics which we will discuss is the staging and prognosis of gastrointestinal neuroendocrine tumors. What are some causative factors that leads to the development of the tumor and the genetic mutations associated with the gastrointestinal neuroendocrine tumors. So the staging of the tumors, we have one is the TNM method of classification, and then we have also the one is the European method of staging, and then the other is the American Joint Committee of Cancer method of staging. So according to that, we have pancreatic neuroendocrine tumors. We have T1, T2, T3, and T4, three stages. And one is confined to pancreas, and the size is less than 2 centimeter. Again, confined to pancreas. Now the size is from 2 to 4 centimeter. Confined to pancreas more than 4 centimeter, or invasion of duodenum or bile duct. And then fourth is invasion of adjacent organ or major vessels. So these are the four types, T1 to T4, according to the European method of staging. In this also, it's confined to pancreas 2 centimeter, confined to pancreas more than 2 centimeters. Then we have peripancreatic spread, but without major vascular invasion. Then celiac, superior mesenteric artery, and major vascular invasion. So pretty much the same size, less than 2 centimeter, then more than 2 centimeter. Then third is without major vascular invasion. In that case, we have invasion to duodenum or bile duct, not the major vessels. In the second, which is the appendiceal neuroendocrine tumor, again we have T1, T2, 3, and 4. There is less than 1 centimeter invasion of muscularis propria, less than 2 centimeter and 3 millimeter invasion of subserosa mesoappendix, more than 2 centimeter or less than 3 millimeter invasion of subserosa mesoappendix, invasion of peritoneum, other organ. So again, as the stages increases from T1 to T2, 3, and 4, the severity of the illness is more, the prognosis become poorer and poorer. So in this, T1A is less than 1 centimeter, 1B is more than 1 to 2 centimeter. Then we have more than 2 to 4 centimeter invasion of cecum, 4 centimeter or invasion of the ileum, invasion of peritoneum or other organs. So these are the two methods of staging according to the European method of different staging and the American Committee of Cancer, and they are the two methods used for the staging of the carcinoma. Prognostic factors. We have lymph node metastasis and extrahepatic metastasis. Very important factor in the prognosis. If the tumor is metastasized to the lymph node or the extrahepatic metastasis, it means the prognosis will be poor. Depth of invasion is also a very important prognostic factor. Rapid rate of growth, if it's growing rapidly or if it's growing slow. Histological features and necrosis, death of the tissue is another factor. presence of cytokeratin, elevated alkaline phosphatase, older age circulating tumor cells, and flow cytometric results. So all these are the different prognostic factor that helps to find out if the tumor or the cancer has good prognosis or poor prognosis. Worse prognosis with the gastrointestinal neuroendocrine tumors if it's associated with carcinoid syndrome, if it's male sex, presence of symptomatic tumor, presence of various molecular features, and then with the pancreatic neuroendocrine tumors or gastrinomas, if it's female sex, overexpression of HA-RAS or P53 genes, absence of MEN1, multiple endocrine neoplasia 1, higher level of tumor markers, presence of histologic features. So these are the features which are associated with poor prognosis. If they are present, prognosis is very poor. In gastrointestinal, male sex. In pancreatic, it's worse if it's in the female, not the male sex. And then we have some mutations which are present if they will have worse prognosis, and then some histological features which have worse prognosis. And in gastrointestinal, if it is associated with carcinoid syndrome, then it will have worse prognosis. And then molecular feature in both, if they are present, then it has worse prognosis. What are some causative factors due to genetic disorders? Loss of tumor suppressor gene. MEN1 is a common cause. Patients with MEN1 or multiple endocrine neoplasia 1, there is 80 to 100% develop non-functional pancreatic neuroendocrine tumors. So patients who have MEN1, they have 100%, about 80 to 100% chance of developing pancreatic neoplasia. Functional pancreatic neoplasia in neuroendocrine tumors in 20 to 80% cases. 54% have Zollinger-Ellison syndrome. 18% have insulinomas. 3% glucagonomas, 3% vipomas, and less than 1% GRFomas and somatostatinomas. So patients who have multiple endocrine neoplasia type 1, mostly they have about 80 to 100%, they have associated pancreatic neuroendocrine tumors. Also in 20 to 80% they have functional pancreatic neuroendocrine tumors. Then we have 54% Zollinger-Ellison syndrome, insulinomas, glucagonomas. So patients with multiple endocrine neoplasia or MEN1, they have multiple features that are associated with these, or multiple conditions are associated with them, and mostly they are hormone related, insulinomas, glucagonomas, and then all these different hormones, they have a tendency to produce different features and signs and symptoms. Genetic syndromes associated with the carcinoids. These are some syndromes which are associated with carcinoid, multiple endocrine neoplasia, MEN1, we already talked about MEN1. Then we have von Hippel-Lindau disease, Von Recklinghausen disease, neurofibromatosis is also known as neurofibromatosis. And then we have tuberous sclerosis. These are some syndromes which are associated with the carcinoids. Location of gene in these multiple endocrine neoplasia. The location of gene mutation is 11q13. In von Hippel, we have 3q25. Von Recklinghausen, we have 17q11.2. Tuberous sclerosis, we have 9q34. And then we have also 16p13. All these are the different genes which are mutated in different syndromes. Then neuroendocrine tumors seen and how frequent they are seen. 80 to 100% develop pancreatic neuroendocrine tumors. We already mentioned in the previous slide that MEN1 is very commonly associated with pancreatic neuroendocrine tumors. They are microscopic. 20 to 80% they have clinical non-functional gastrinomas, insulinomas, and then we have carcinoids, gastric, bronchial, and thymoid. So these are all the how common the neuroendocrine tumors are present in multiple endocrine neoplasia. Then in von Hippel-Lindau disease, 12 to 17% develop pancreatic neuroendocrine tumors. In von Recklinghausen disease, we have 0 to 10% develop pancreatic tumors, primarily duodenal, somatostatinomas, insulinomas, and gastrinomas. And then tuberous sclerosis uncommonly develop pancreatic tumors. So that's how common these pancreatic neuroendocrine tumors are with these 4 syndromes, and what are the genes that are affected in these 4 syndromes. Neuroendocrine tumors associated phacomatoses. 3 phacomatoses associated with neuroendocrine tumors. We have von Hippel-Lindau disease, autosomal dominant, defects on chromosome 3p25, cerebellar hemangioblastomas, renal cancer, and pheochromocytoma. 10 to 17% develop pancreatic neuroendocrine tumors. Other phacomatoses is von Recklinghausen disease, which is defect in neurofibromin forming gene. 10% develop upper GI neuroendocrine tumors, classified as somatostatinomas. Then we have tuberous sclerosis, Bournville's disease, mutations altering hamartin or tuberin, insulinomas and gastrinomas, and Mavish disease. So these are the phacomatoses associated with neuroendocrine tumors. We have von Hippel disease, von Reckling disease, tuberous sclerosis. Autosomal dominant is the von Hippel disease, and then we have different chromosome and gene mutations that can lead to these phacomatoses. Genetic mutations in oncogenes. Oncogenes are the genes that leads to tumors. Onco is for cancer or tumor. So these oncogenes, what are the mutations that can lead to the tumors? We have RAS, MYC, FOS, SRC, and JUN. Alteration in tumor suppressor gene P53, P16/MTS1. Gene amplifications occur in MDM2, MDM4, and WIPI. So these are different mutations occur in the genes that can lead to the tumors, and also there is gene amplification in these different genes. Changes in DPC4, SMAD4. Then we have HER2/NEU gene amplification, alteration in TFSHOXC6, alteration in growth factor, and mutations in MEN1 gene is rare. So these are genetic mutations that can lead to neuroendocrine tumors, and we saw there are a lot of genetic mutations, gene amplifications, and alteration in tumor suppressor genes that can lead to the neuroendocrine tumors. Anti-tumor activity or these are the drugs everolimus and sunitinib. They are also used for the treatment of the tumors. So everolimus and sunitinib. And then also any activity that can avoid or that is considered as anti-tumor activity. So that was all about this section. Thank you for watching sqadia.com.